Okay, and now we come to the discussion of cases. So the first case is by Howard Oster, and I would like to call the debaters, so the expert panel of Rafael, Bejar, Rena, Buckstein, and Arjan. You don't move, you come back immediately. And we are really anxious to listen to the cases. So in the interest of time, the cases will be 5 minutes, and then 15 minutes for the discussion. So lively discussion, I hope.
Right, I see that. Right. No, have to go back one. There. Okay. Good morning, everybody. I'm Howie Oster from Israel, and I'd like to present two cases of patients with high-risk MDS. So we'll start with patient number 1. This is a 70-year-old woman who presented last year with weakness, fatigue, and weight loss, about 10 kilograms. She has a past medical history of hypertension, hyperlipidemia, very heavy smoking history. On physical exam, she's pale, she's cachectic, and she shows signs of her smoking history with wheezes and prolonged expiration. On laboratory, she has a mild anemia that's macrocytic, mild leukocytopenia, and neutropenia. Her platelets are fine. And on bone marrow, she has hypercellularity with trilineal dysplasia and blasts of 12% with a karyotype of del5q. NGS shows no mutations. So she was diagnosed with higher risk MDS, and we asked whether we should treat her with azacitidine, whether this is the time for transplantation. Well, azacitidine was initiated. We asked at that point, should venetoclax be given? And we decided no, or not yet. So she was treated with azacitidine. She did not tolerate it that well. She had decreased counts. She had reduced doses to modify, and she had delays in treatment. She had infections, admissions to the hospital, and she was given supportive care with RBC transfusions. After 6 cycles, somehow she managed to complete those. She had improved symptoms. She gained weight, but she was still anemic, but she did not require transfusions. Her bone marrow at that time showed 3% blasts. So we asked, what now? Should we continue with the azacitidine? Should we think about transplant at this point? Well, while we were deliberating during the course of about 2 to 3 months, she had symptoms again and started losing weight, and her blasts were up to 7%. And so she was given azacitidine for 3 more cycles, again modified in terms of doses and timing. Still poorly tolerated with supportive treatment required, but after 9 cycles, she did achieve some sort of stability. She had mild symptoms, but she was active. She required RBC transfusions, but about every 3 to 4 weeks, and her hemoglobin remained about 7 to 8. Her blast at the last bone marrow was about 6 to 7%, and she still had the del5q. So now we ask, what next? Well, before we discuss that, we're going to go on to the next case. This is a 74-year-old man who presented in 2017 with asymptomatic anemia. He has a past medical history of hypertension, hyperlipidemia, diabetes, coronary artery disease. His exam was normal, and on bone marrow, he just had mild dyserythropoiesis with blasts of about 1%, normal karyotype, and he was diagnosed with very low or low-risk MDS, and the management was just follow-up. Fast forward to 2023. Now he has symptoms, weakness, fatigue. He's anemic, macrocytic. He has leukocytopenia with mild neutropenia, and you can see that his platelets are dropping to 95. His bone marrow is similar, but with these blood counts, we have concerns. And the next year, 2024, remember that he's now 81 years old. His symptoms are worse. His blood counts continue to drop. His bone marrow shows hypercellularity with dysplasia in both the erythroid and the myeloid lines. His blasts are now 11%. And his NGS shows TET2 with a VAF of 35%. So now his management is clearer, and he's given azacitidine. He manages 6 cycles, does not tolerate it that well like the first patient, and requires reduced doses, and treatments are delayed. He has supportive care. But when he comes into the clinic, he says he feels better, he's active, He has bone marrow that shows blasts of about 6%, and we decide to continue the azacitidine. And after 10 cycles, he feels okay. He says in the clinic, I feel okay. And his hemoglobin is about 7.7. It's significantly lower. His ANC now is 800. His platelets are 16,000. He requires RBC treatment every week or two, GCSF, platelet transfusions. And his most recent bone marrow, his blasts are 7%, and the NGS shows a TET2 that went from 35% to 44%, and now he has the EZH2 with a VAF of 50%. So now we ask in both of these cases, what's next? And I'll put up the questions that we want to discuss. Number one, we talk about the comorbidities. What is their role? Do they have an impact on the prognosis, and should they be part of the classification? Do they affect treatment decision? When we give hypomethylating agents, should they be given alone or in combination of others? And what is the role of venetoclax now, especially where we stand now after studies of the Verona in 2025? What about transplant? What's the timing? What is the appropriate age or the age limit? Do we require complete remission? Should we treat with azacitidine beforehand? What about the patient who's transplant ineligible? What do we do for him? And what's the recommended approach for patients that are partial remission? And of course, with all these, what we presented with those two patients, which are similar to many of our patients, the azacitidine side effects, what do we do about it? And is there a significance, finally, is there a significance to the VAF that increases? Lots of questions. Good luck. Thank you. Wait, let me keep that last slide on.
Thank you.
I'm going to put those questions back on.
I think we'll just
To start.
okay. So,
Okay.
Thanks, Howard, for these cases. And, these are typical cases that we see in our practice all the time. So specific to comorbidities, absolutely comorbidities play a role. They independently add prognostic value to the IPSS, the IPSS-R, yet to look at the IPSS-M, but I predict that they do. But probably even more important would be frailty. And because some patients are comorbid without frailty, and some patients are frail without comorbidities. And in work that we've done in the National Registry in Canada, we've shown that frailty actually supplants comorbidity. And in fact, the only comorbidity that was important in a frailty-specific metric for MDS patients called the FS15 that we developed, the comorbidity that was important was previous cardiac disease. So it is important, but if you had to choose between doing a frailty measurement versus comorbidity, I would say frailty would be important. Now, with regards to eligibility for transplant, no question, the HCTCI is used readily by all transplanters to determine whether or not someone should or should not have a transplant. But I want to direct people to a new measurement called the CHARM measurement. And there was a lovely paper that was recently published by LeBlanc et al. Evaluating the impact of CHARM at predicting not just non-relapse mortality, which is what it was developed for. And by the way, the CHARM is comprised of not just the HCTCI, but also weight loss over the prior year, Karnofsky performance status, CRP, albumin, cognition by MoCA, and patient age. And the CHARM, which not only predicts NRM, also predicts frailty and disability-free survival. So in terms of counseling your patients, how well they're going to be, even if they survive the transplant, the CHARM has been validated to be very useful. So absolutely.
Yes, Valeria? It's quite clear what you have said. If you go back to the patients specifically from Howard, thank you for the cases, Howard. The patient's first patient of 70 years old with a lot of comorbidities. So I can argue also that a transplant was not the best way in a del(5q) in that specific way. If you look to the del(5q), now at the end, patients after azacitidine, the only aberrancy is still del(5q) with low blast count. It might be considered to use lenalidomide in this specific case. So, although in the beginning there was an increased blast count over in your document, it was first 10%, but now it was 12% on your slides. Okay, if you calculate that to the IPSS molecular by the isolated del(5q), you might argue to start with lenalidomide, and even now, after ASA failure. So that is a discussion I would come up.
But the blasts are 6 to 7%.
Yes, that is high, and according to the registration, to the criteria, it's not an isolated delta Q per se, or a little bit more. But on the other hand, there is no signs of further cytopenia except for the anemia. So you might consider, because transplant, by what Rena was saying, was not a possibility, I think in this case, due to the comorbidities, the cardiovascular disease, it might be an argument. But maybe...
I think those are reasonable options to consider. I think one of the things we have to think about is what are our goals of treatment. I think initially when you treat a higher risk patient, the idea is to not only reduce the blasts, but to improve survival and of course improve the blood count so the patients are no longer transfusion dependent. But if we can achieve any of those things, I think we're accepting of that therapy, might continue it while that's the case. So one option is to continue what you're doing and support the patient and move on. But I do get concerned that that isn't going to work long term in a patient who has excess blasts. And you raise the question of whether venetoclax might be appropriate for this patient. We know the top-line results of the Verona study were negative, but it doesn't mean you have to give the patient a regimen that's exactly like was in the Verona study. Venetoclax is particularly effective at reducing blast count, often within a single cycle of treatment. And even though these patients have a lot of comorbidities that might preclude them going to transplant, you might be able to find a way to combine them with venetoclax to reduce the blast count, perhaps improve the blood counts, improve the transfusion dependence. And that's something that I would consider in a patient like this with careful monitoring during that first cycle, given their experience with AZA alone.
And Dr. Garcia Minero's presenting a subgroup analysis from the Verona study at this meeting in an oral abstract, and definitely showed that there are certain subgroups and certain genetic subgroups that seem to benefit more from Verona, as well as younger patients. So this patient less than 75, and this patient was less than 70. I mean, I think at the front end, it's, again, without really seeing what the patient looked like, what their performance status was, I wouldn't say transplant was off the table just because of those comorbidities. So if the goal was to get to transplant, I would agree that's probably the quickest way of achieving that.
Yeah, I think in general also the kinetics is always very important. What's how evolving the blast counts. In both cases, you have a reduction, a major reduction of blast cell count. So you might argue that the blast reduction makes not sense specifically in these cases you presented. Also in the old 81-year-old man, the toxicity of ASA could be maybe a little bit handleable, how do you call that? Manageable.
Mitigated.
Because of mitigation of the dose. 50% reduction, but not every 4 weeks or less. And then normally the toxicity, the myelosuppression or other complaints might really go down. So there are possibilities as supportive care maximum, disease control, in this case, no kinetics, so venetoclax might not be an option because also you don't go to a transplant, and there are the arguments, I think.
I think one of the questions was, should you stop azacitidine in patients? And I think that, the consensus is that most patients will relapse quickly if you stop azacitidine. You're not eradicating the clone. You're suppressing it, but you're not eradicating it. So it shouldn't be, but as Arjan said, you can kind of play around with the dose and the schedule to make it more tolerable for the patient. Sometimes even 6-week intervals. Some patients very far out. I have patients who have been on AZA for 2.5 years, coming every 6 weeks, and they're getting a slight 5 days instead of 7 days. So there's an art to giving azacitidine. G-CSF can be used if you've had a blast reduction as well. But it shouldn't be stopped. The patients who have been on it for at least 12 months, however, have better progression-free survival than people who have been on it less than 12 months. So definitely don't take patients off before 12 months. And then,
I want to hear about what Rena just said regarding the clones and the importance of the oscillation.
About whether you have to clear the clones to do anything. I think there is an association with improved outcomes in patients who do have a reduction in their clonal burden of disease. But it is clearly not a requirement for that to happen in order for patients to receive benefit from the hypomethylating agents. There are some patients who do get some improvement in blood counts without any change in clonal size or even with clonal evolution. So I wouldn't use that as a gauge for what to do with therapy necessarily, although when you do see the clonal reduction occur, then you're likely to have a more prolonged remission or a prolonged degree of benefit. But with regard to transplantation, I don't think you need to achieve that before you go to transplant. You certainly don't need a CR, you certainly don't need clonal reduction. Those things may be prognostic of outcomes after transplant, but you can certainly just proceed to transplant if that is an option.
Right.
And I think there was a published ESBMT study a year or two ago that looked at the impact of reducing the risk score prior to transplant with either intensive chemotherapy or hypomethylating agent. And the party line was that the outcomes of patients that were untreated were just as good as patients that were treated who either stayed stable or had improvement. But the patients who got treated and had either with hypomethylating agents and either had worsening of their risk score or progression in their disease prior to their transplant did worse. But I think the conclusion was you actually don't have to treat patients to get them to transplant. The major problem is, as Arjan said, is kinetics. So if someone's blasts are rapidly increasing from month to month, that's a patient, you're not going to get them to transplant in 3 weeks. And so you do want to kind of control things for a while, so HMA would be warranted. But in someone with like 8% blasts, that's kind of stable, counts are stable, I think you don't necessarily have to consider giving hypomethylating agents. There's no evidence, at least from this retrospective data, that debulking them improves their outcome.
I note it was a retrospective. I would highlight
Yes.
it because it was not prospectively randomized and therefore some reluctance, but I fully agree kinetics is, I think, important in that perspective.
Okay, thank you very much for the first 2 cases. And then I call Albert Kolomansky now for the lower risk MDS cases to discuss.
Right. Move the slides. The green one. This one, okay. Okay, good morning, everyone, and thanks to the organizing committee for giving me the opportunity to present these 2 cases. So the first one came to our attention in 2021. This is a gentleman. He was back then 65 years of age, complained of some weakness and some fatigue. This is his past medical history. He had atherosclerotic cardiovascular disease, some sleep apnea. And then in his CBC, he had anemia, a mild anemia of hemoglobin of 10.5, mild microcytosis, normal white blood cell and platelet counts. There was no iron or other deficiency. And sure enough, bone marrow was done. On the aspirate, it was and biopsy, actually, it was hypercellular with cellularity around 80%. There was dyserythropoiesis, no excess of blast, but a significant amount of ring sideroblast was noted. His karyotype was remarkable for 20Q minus abnormality, and NGS panel demonstrated several abnormalities, actually, including RUNX1, TET2, DNMT3A, and also, not surprisingly, SF3B1 mutation with variant allele frequency of above 40%. So the diagnosis of MDS-RA-RS, which was previously the term, was done, and according to, it was low risk according to IPSS-R and IPSS-M, and it was decided to follow him up. In the end of 2022, he became symptomatic. His hemoglobin dropped as low as 6 grams per deciliter. He maintained normal white blood cell and platelet count. He had some anginal symptoms. He sustained a significant COVID-19 episode. His function deteriorated. The repeat bone marrow angiogenesis actually yielded the same picture, although his cellularity went up to 100%. Understandably, he became a transfusion dependent, actually heavily transfusion dependent, with 2 to 3 units of blood per week. Unfortunately, though, ESAs failed even at high doses, both with recombinant erythropoietin and darbepoetin. And then luspatercept was actually considered, but unfortunately, the patient had no access to the medication due to reimbursement issues. Imetelstat was not an option. So other modalities were considered, which including the transplant and hypomethylating agents. Fortunately, in the middle of 2023, the patient did get an access for luspatercept, and it was approved, and he immediately started the medication. And as we say, one picture is worth 1,000 words. You can see a dramatic response to this medication, to luspatercept, with increase in hemoglobin up to 12 or even 12.5%, and even at some point, the dose had to be reduced. So currently, the patient is doing well. He's very mildly symptomatic. His hemoglobin is maintained at 11.5 grams per deciliter. He's still low risk, and we hope for him that he will continue to be in a good condition in the next couple of years, but we have to think, of course, what would be the next step when he progresses. So the second case is slightly different. This is a 78-year-old patient. He's had asymptomatic anemia for quite some time, and then there was some progression. He became mildly symptomatic, or very mildly symptomatic, with hemoglobin dropped to 8.6, with macrocytosis, normal white blood cell, and platelet count. Bone marrow was done. It was hypercellular, with both erythroid and megakaryocytic dysplasia, but no ring sideroblasts in this case. There was no excess of blasts, normal karyotype, both by G-banding and FISH MDS panel, and MGS yielded actually in a single DNA T3A mutation. So this is a list of questions that we offer to the panel. The first, what are the indications for transplant in low-risk MDS patients? Is there any significance for very high cellularity, like 100%? Does SF3B1 mutation always have a fairly good prognosis? Maybe when it comes as a co-mutation, it's somewhat different. What is the first-line treatment in symptomatic transfusion-dependent patients? Is it still ESAs, or maybe we should move to luspatercept or imetelstat and so on, whether in both in SF3B1 mutated or unmutated or RS negative patients. When luspatercept fails, like it could happen in the first case, what would be the next step? Either imetelstat, HMA, transplant, and finally, what is the hemoglobin threshold for anemia treatment, mainly in non-transfusion dependent patients? As the first line, should we stick to the traditional ESAs, or maybe we should move on also to newer novel therapies? And lastly, actually, is there any significance to variant allele frequency of different mutations, whether it could have any implementations to selecting therapy? Thank you.
Thank you. And now open to debate. Rena, start.
Okay. So first of all, I'm going to just tackle how I would have treated these two patients based on the evidence. I'm going to make the assumption that the EPO levels were below 500 for both patients. So they were not provided, but I'm assuming the fact that ESAs were tried and then luspatercept were tried, and the evidence is only in patients with an EPO level less than 500. So for the patient with the SF3 beta 1 mutation, if I didn't live in Canada and I lived in the wealthy United States, I would be using luspatercept as frontline therapy for that patient based on the results of the COMMAND study that incontrovertibly show that these subgroups of patients have higher erythroid response rates and durability with luspatercept. For the second patient that is non-SF3 beta 1 mutated, again, I would want to know what the EPO level is. If the EPO level was over 200, I would think that they're very less likely to respond to ESA, but it would not still be unreasonable to try an ESA first. It's more economical, knowing that their response rate's going to be lower based on the results of commands, and then followed by luspatercept if again in the United States it was available, not in Canada because it's only for patients with ring sideroblasts. So definitely the EPO level is needed, and whether or not they're SF3 beta 1 mutated. Of course, the frequency of their transfusions, the more transfusion dependent, the lower the rates of response to both, and in particular to ESAs.
Yes, I fully agree with Rena. This is the same we do in Europe, or at least in the Dutch community, like you say. The question also is now the indication in that 67 years old first patient with potentially now a refractory of less responsive to luspatercept, and when to go to a transplant in the lower risk MDS. That's also one of the main questions. And in generally, what I think is that transfusion dependency for young patients is one of the indications. However, if you have an indolent disease, like the MDS SFTB1 mutations as a single mutation, you might still argue against a transplant, especially in this 67 years old man with a lot of comorbidities. However, we don't know, but that could be an argument not to transplant. And if then refractory on luspatercept of lose response, then go to a clinical trial, if there is a trial, or to imetelstat thereafter. That could be an option. The question that SFTB1, in the first case, there was a RUNX1 mutation. So actually, it is not defining MDS with an isolated SFTB1. That might also be different. Maybe you can comment others on the role of the RUNX1 in that specific entity, and then argue that maybe a transplant is better than to wait.
Yeah, I think you do have to consider risk, keeping those mutations in mind. But it sounds like your patient did have a really robust response and actually still had hemoglobins in the 11 gram per deciliter range. Yeah. So any symptoms that they have are probably not due to their anemia. Yeah. I would ride the luspatercept for as long as I possibly could in that patient before considering options like transplantation.
If at all.
Yeah, exactly. So one of the issues with nomenclature is that we call these patients lower risk based on how they would score on the IPSSM, for example. But if they've exhausted all the therapies that are available to them and they remain transfusion dependent, then they're clearly not low-risk patients anymore, even if they don't have excess blasts or complex karyotypes. So for me, that exhaustion of therapies in patients who still need some sort of treatment to address their symptomatology is an indication for transplantation. Normally, I would try maybe some higher risk therapies before getting to that point, like a shorter intensity schedule, a hypomethylating agent, for example. But I don't think we should call those lower risk anymore.
Hypermethylation in lower risk as a second or third line? Is that pre-transplant?
To achieve transfusion independence.
And then go to a transplant.
If they become transfusion dependent again.
Yeah, MD Anderson has done a study where they did a reduced intensity treatment, 5 days of azacitidine or 3 days of decitabine, that has very similar response rates to what we see in the high-risk population with perhaps less toxicity. And it does help patients respond and no longer be transfusion dependent. So it's something I would consider in a lower-risk patient.
May I comment? Mm-hmm. The other indication might be that there is a more progressive granulopenia, or a thrombocytopenia, which is also a sign of a change in the biology of the disease, yes, which might go to your argument to go to a transplant if the transplant comorbidity scores or other scores you mentioned might fit with a good outcome, independent of the conditioning.
Can I ask you something, all the three of you, how much is IPSSM determining your choice? So if you have a low-risk IPSSR who has an IPSSM high or moderate high, what is your approach? Which one would you consider?
Yes, so that's actually increased the number of referrals that I make for transplants because of, again, a recent Markov model that showed that moderate high, and very high IPSSM patients seem to have maximized life expectancy if you transplant early rather than late.
Young patients.
Younger patients.
Younger. Yeah. The one above 60
low risk
do not seem to be to get such a big advantage from an early transplant.
I think actually in the younger patients, even the moderate low seem to benefit from transplant as well in that study. So it's even, that's for older patients, moderate high, and very high, and for younger patients, moderate low, and higher benefit. So no question, it was very important to calculate the IPSSM, which I did for those two patients, and both were kind of on the lower risk scores, so I hadn't recommended it. But yes, definitely referring more patients for transplant based on the IPSS-M. And we know that 47% are upstaged by the IPSS-M, and of those, or have a change in their classification, of which 75% are upstaged.
I think that's the major impact of the IPSS-M, is identifying those patients that may benefit from transplantation. I don't use it in order to justify using higher risk therapy in a patient who wouldn't otherwise meet criteria for that. I think our decision to use a hypomethylating agent really depends on the clinical picture and not necessarily the score that you see.
I agree.
I agree. And note the behavior of a MDS, low risk MDS, might be transforming to an aggressive disease, but on the other hand, the bone marrow failure compartment, and that is the balance you have to do. Then the leukemic burden is not a question, but then the clinics, the bone marrow failure component, and especially in those IPSS molecular lower issues, there's 1/3 never progress, but.
I agree, but it is sometimes difficult to choose the more aggressive way. If you have a patient who has moderate anemia or moderate cytopenias, but high IPSS-M risk. So then it's very difficult, but we are starting now to see this sort of patients, and we should really try to see prospectively what is the best. So the model is quite clear, but the implementation in clinics is still to come, I think.
And I think, addressing one of these questions is, what do we do about increasing variant allele frequency or the emergence of new clones? That may also help, determine whether or not you're going to refer to a transplant sooner rather than later, because it seems that the biology of the disease is evolving and that they may be closer to developing acute leukemia than the other patient whose VAF is staying the same or declining. Or the VAF is very small. And Arjan, you mentioned something about the RUNX1 and co-mutations. And so, in preparing for this, I came across a lovely study that I think Valeria is a co-author on, in this real-world study of a combination of the largest cohort of luspatercept-treated patients from the Moffitt and FISM, and they looked at the response rate of luspatercept in the real world. And they actually kind of arrived at this sort of SF3 beta 1 alpha versus beta, which is the alpha, the beta, which has co-mutations and some unfavorable mutations like BCOR, BCOR-L1, NRAS, RUNX1, which our patient does, had an SRSF2. They had lower response rate to luspatercept than SF3 beta 1 alpha. Now, would have, I'm going to ask Valeria, would that stop you from trying luspatercept in that patient population? Or would you think, okay, they have a lower chance of response?
Well, not really, because we do not have other options for this kind of patients. So, and again, response was not zero.
Yes.
Response was less than the one we see for SF3B1 alpha. And anyway, even for the patients who had response, there was finally an advantage in overall survival. Not as much as we see in the real responders, but still.
But does it argue to go to a more intensive treatment regimen earlier if you have the co-mutations? Although your response to luspatercept might be less. You first try luspatercept, yes, and then might differ to think about the next step, the transplant. That is the other question.
Although it's hard for me to get, I sometimes will still try lenalidomide in a few patients with non-deletion 5q MDS. I've had patients who've responded 2.5 years on lenalidomide. It's hard to get, but there may be, that's another agent to consider in somebody who remains low risk without any adverse high risk mutations, or who is clearly not transplant eligible. So there's the HMAs, and then there's also lenalidomide.
See, all these drugs are off-label, but they still showed some, of course, some activity. So we should, again, go back and see which are the patients who respond.
Yes, we have it now in our guidelines. It was already in the NCCN guidelines, the use of len in the non-del 5q, and in our community also we now point it out based on evidence on the trials to also put it in for the non-del 5q, etc.
Yeah, but before luspatercept here in the US, in the Medicare survey, the lenalidomide was used more in off-label for non-del(5q) than del(5q). So it is, you know, some patients do respond for a very long time.
And do you combine it with an ESA, or do you give it by itself?
Well, the French group combined it with ESAs and had very good results. We evaluated as a single drug, and there was, in some cases, a very good response. Less than 30% overall in the ITT, and 42% response, TI response in the patients who had serum EPO lower than 100 units.
And actually,
so you see, you may extract the patients who are responsive.
Within one of the Hoven trials, we did also ESA-Len, and it does not help any. It does not add additional value.
Okay.
But there were also some signals of response, higher response for molecular subgroup.
Right.
And this is something we should look more and more, because we don't know whether we can select patients for specific therapies on the basis of not target therapy, but just some therapies.
To comment on that, in the SLDB1 mutated ones, before the luspatercept era, they do not respond on the combination ESA-Len. It's just interesting, so you have more new combinations in the non-del(5q) setting.
And I think there was also a lower rate of response in non-deletion 5q to lenalidomide if you had an ASXL1 mutation. It wasn't statistically significant, but there's definitely a signal. I think you showed this, Valeria, that they don't do very well with lenalidomide.
DNMT3A was the best.
Yeah,
also for overall survival.
That stresses the former discussions we have had with Robert in the diagnostic, that the profiling predicts to some extent also the chance of response to the newer drugs, and therefore.
That's right.
Yeah.
That's right. We're going to be hopefully using some of these genetics to help decide, should we choose this one over this one based on what mutations they harbor. I'd like to ask my colleagues about the initiation of therapies in anemic patients who aren't transfusion dependent. That's one of the questions. So, you know, my practice is at all costs to try to avoid transfusion dependence, because we know it correlates with bad survival and leads to iron overload and the complications thereof. That may in itself help. The iron overload may contribute to the ineffective hematopoiesis. So my practice is to avoid transfusion dependence like the plague and initiate my therapies early. Is that your practice? And have there been any kind of financial implications or regulatory implications for funding for non-TD patients?
Yeah, I mean, I practice in the US, so we don't even have to think about those things, right? But that is definitely my approach as well. I think now we are starting to see some evidence to suggest that the phase 3 trials of ESAs that were conducted in Europe actually included patients that were not transfusion dependent, and they seem to have similar, if not better, benefit than patients who were more deeply transfusion dependent. And the Central study we have with lenalidomide also suggests that might be the case with that drug. But even with luspatercept, I tend to use it when patients are approaching that transfusion dependence threshold and not waiting until they get there, because they're symptomatic before they get transfusion dependent.
The only critical point is if you have a disease which is not per se dramatic in the first 3 to 5 years, that you use a drug too early, although preventing transfusion dependency, I agree with all the consequences. However, the data should grow whether or not we select clones by lenalidomide, for instance. That is, although in a Sinta study it was not shown, I think, but too early might also escape your treatment for long-term treatments or clonal evolution, and thereby that might. Although in the ivosidenib studies, we don't see any changes in FAF at all, although they respond. So it's... And
higher, as you pointed out, higher rates of cytogenetic remission, like 90% in the Centro-Rev study, whereas it's lower in the 003 and 004 studies.
Which could actually reduce the rate of clonal evolution.
Right.
Yeah.
Right.
So.
Okay, thank you very much. It was a very fruitful debate and discussion.